friends. I was given a task in the Indian Academy of Echocardiography conference to present on guidelines, and many a times we read guidelines when everything else fails. Then let's go to find out what are in the guidelines. And many of us still believe that rules and guidelines are for the fools. That's not true. So these are the recent guidelines published in January this year, and these guidelines actually give you insight into prosthetic valve functions and dysfunction. And these guidelines recently have included the multimodality imaging rather than just an echocardiogram. So there, these guidelines were long awaited. It took them 25 years to publish one. Now look at 15 years, in fact, and these guidelines were published by Zogby and from Methodist Hospital, U.S. Boston, and we still remember our good old friend Dr. Khanderia. May his soul rest in peace. In between, we had guidelines on 2016 from European Society, and this was European Association of Cardiovascular Imaging in association with the Chinese Society, Inter-American Society, Brazilian Society put together on a cardiovascular imaging of the prosthetic valves. And we do understand a lot of people in the world are suffering from valvular heart disease, and about 4 million of them have been replaced. The valve have been replaced in past 50 years, and we would continue to follow up these patients by various techniques. So it's a good idea because the numbers are so huge. We need to know details about the assessment of the valve. But before we begin assessment, let's discuss what are the types of valve we have available. We have mechanical valves, we have bioprosthetic valves, and they are of different kinds. Georg Shelley valve and Star Edward is the valve where it's ball and cage, which we don't see these install these too frequently, but people, those who've been installed the valves long back, we still have them on follow up. So once in a while we do get a patient with the ball and cage valve, but this is the commonest valve, a bileaflet valve, which is being used. This also has been sliding disc has been withdrawn, and we do not use them anymore. There are specific indications of stent and without stent valves, of a bioprosthetic valves, which also would include valves like a TAVR and a MAVR there can be assessed. I think we do everything else, but probably we are missing on these two parts, auscultation and the blood pressure measurement, before we begin scanning the patient. This is something very, very important. We must all do that. Even today, fluoroscopy makes a very important aspect of assessment of a prosthetic valve, whether you are looking at the valve in a profile view or an en-face view. This gives you a very good movement of the occluders in the valve, particularly in the mechanical valve. Echocardiography probably is the best modality to make an assessment at the starting point for screening of the valves which appear normal, and in case of any clues or abnormalities, or we don't are unable to see certain things, we resort to a transesophageal echo and three-dimensional echo. Put to both transthoracic and transesophageal echo gives you an additional information. CT scan is becoming a very good modality these days for some areas where TEE and transthoracic echo are not competent enough to give you a final assessment, a diagnosis. CMR, we initially thought that we have a metallic substance inside the heart, may not be an adequate way, but we are getting good cardiac MRIs, which can give you good assessment of the valve, particularly the bioprosthetic valve, the valve thickening, and so many other things. But at the end of these guidelines, we have these charts available. This is the size of the valve, and then what is the mean gradient and effective orifice area. These tables are very, very important. Good idea probably to print them or put them on your mobile in a digital form. So whenever you have a patient, so that's something which is very very important. You need to ask which which valve has been replaced, because that's going to change the gradient and where you're going to assess the valve. Again, this is the old guidelines which showed a normal values of a bioprosthetic valve in aortic, mitral, and tricuspid valves. Once you're talking about a 2D imaging on a 2D echocardiogram, we do understand that these mechanical valves would produce shadowing because of absorption or reflection of the sound waves, and you get these shadows behind the valve and you don't see the structures. And then the mitral valve position, and if you are in a four chamber view, you don't see left atrium and what is happening in the left atrium. So similar, these are the caveats which we must understand in the mechanical valve. But if you use a transesophageal echo, you can see the heart from the apex side and you can see it from behind. That would cover all the blind spots on an echocardiogram. 2D echocardiogram, when you're examining, you should look for the swing ring, valve, or occluder. You must look at the surrounding area, the pericardium, the aorta, the left ventricle, the left atrium, the right ventricle, and these are the things we should see. And apart from that, we must look into the ventricular functions also. But here are the situations where you don't worry. You don't worry if you see micro bubbles, because they are common, because cavitations do happen because of the mechanical effect of movement of the mechanical valves. You do see occasional strands around of some kind of thread which have been during the surgery, and tags are also seen when you have aorta which has been actually enlarged to put a larger size of the valve. Spontaneous contrast behind the prosthetic valve is pretty common, and I don't think so you should get worried about these things. Now let's on a 2D, we'll show you how the valves look like. This is a bileaflet valve, and this is an opening and closing of a bileaflet valve, and this is the inflow of the bileaflet valve, which is absolutely normal. These are the two inflows of the bileaflet valve. Okay, bileaflet valve in the mitral position, you see an opening and closing here. There are two valves which you see here, right, and there are one opening and closing, and these are the three jets what you get: a central jet, two peripheral jets, which I would show you on the orifice of the bileaflet valve. And then again, this is the bileaflet valve in the tricuspid position. Both the leaflets are opening and closing normally. And this is how the TAVR looks like. This is a little older patient where in the learning curve of TAVR, we see the TAVR going right quite into the left ventricle outflow tract and covering the mitral aortic curtain. And this is the where the valve position is in the ring, and this is a mild regurgitation of the valve itself. And this is the normal flow, and gives a very good profile of the flow when we're using a TAVR. Now this is again, you can see the valve here. This is the patient where mitral and aortic valve has been replaced by a catheter technique, and you can see in the cross section of the TAVR where the regurgitation, usually this is the normal regurgitation paravalvular you should look for, and paravalvular regurgitation at about 11 o'clock position, about 3 o'clock position, and 5 or 6 o'clock position is pretty normal. That's where it commonly happens, and you can see the regurgitation here and the paravalvular leak, which is pretty normal. But I just want to ask you guys, what do you think about this? And let me tell you, this is no mitral regurgitation, actually a reverberation of the aortic forward flow. So remember that artifacts do happen and we should be prepared for that. And this is the TAVR valve where you can see a tri-leaflet valve. Incidentally, this is the tricuspid tri-leaflet valve on the right side. Then we go on to a Doppler. First, let's do a color Doppler and a Doppler studies. In the Doppler studies, we need to have a pressure gradient. We have a dimensionless index, and then we have a acceleration time and ejection and ratio between the acceleration time and ejection fraction. Then we can calculate effective orifice area, and we should make an assessment of regurgitation if it is present. So once you're doing a Doppler CW or a pulse Doppler, the contour of the jet is very, very important, whether it's an early rise or in an aortic valve or it's a slow slope. I mean, that's something which is important. Then you can use VTI of the jet. Then you calculate the dimensionless valve index, which I'm going to show you. Acceleration time and the acceleration time to ejection time ratio is again very important in a semilunar valve, whether it's a pulmonary or an aortic. Effective orifice area, and it should be indexed based on what the parameters the valve has been given, and these are available in the charts at the end of the presentation. Now, another important aspect is the bioprosthetic valves. Uh, they also can cause a pressure recovery phenomena, but it's far more common in Georg-Shelley valve, where you have a central jet which is a high speed jet, and you tend to have a very high velocities here. The pressure recovery phenomena leads to erroneously large gradients across the valve. And when we use a continuity equation, if there is no regurgitation, flow across the mitral and aortic valve, tricuspid and pulmonary valve are almost the same. Again, I was going to tell you about calculation of effective orifice area. In a normal valve, this is how the effective orifices area looks like. But if you talk about Georg-Shelley valve or a bileaflet valve, it has three openings: central one where it is a high speed jet and two peripheral ones on the sides. Then how do you calculate effective prosthetic area? And it is based on the same formulas which we've been using for last many years, and guidelines again have re-emphasized that. DVI again, all these guidelines 2009, 2016 guideline from European Society and the current guidelines have really emphasized Doppler velocity index or dimensionless velocity index, where if you're talking about the aortic valve, is prosthetic aortic valve, you say a VTI of left ventricular outflow and VTI of jet, and then you get this dimensionless index. This takes care of increased velocities across the LVOT because of high cardiac output or aortic regurgitation. So that's why this dimensionless index have been devised. So same dimensionless index is with the mitral valve, but it's kind of an upside down. In this, we take a VTI of the left ventricular outflow tracts and as a nominator, and denominator is VTI of the valve. So that's why there is a change here. Now, what do you see here? Now, this is how the assessment can be made. They have given that you take into account the acceleration time or acceleration time and ejection period, and then you look for the dimensionless index. From there, you can actually make an whether it's a normal or even in a mid-range where you are confused whether it is stenosis or not, and then a lot of other parameters and other modalities might be required. In case you have a late peaking and you have a dimensionless index in the aortic valve less than 0.25, it is certainty that this is a stenotic valve. Again, there's another way of looking at dimensionless index. You can divide as a normal, a mid-range, and an abnormal. We're talking about the aortic valve, and in case you have dimensionless index which is normal or borderline, you have an absolutely good profile of early peaking velocities. This gets normal, and in case you have borderline DVI, border and an abnormal DVI, and there is an increased acceleration time, it's valve stenosis, and then there are situations which are discordant where we need to take into account other modalities. Giving you an example of a patient with the velocity is about 3 meter per second plus, and you have an acceleration time. Look at the profile here. An acceleration time is less than 100, and the ratio is okay as compared to 126 acceleration time and increased velocities across the aortic valve indicating a stenosis. Again, the cartoon showing the same thing on this side. Now, guidelines further gave these images, and this is important that we can, on a CT scan, can look at the opening of the bileaflet valve. We can see the angle of the opening on either side. In case one is stuck, we can actually come to know this is NFAS, what we can see. Again, on a three-dimensional transesophageal echo, we can have the valve in the mitral valve position shown such a nice way. MRI can give you the flow velocities, the regurgitation fractions, apart from looking at the myocardial dysfunctions in these patients. Now, prosthetic valve dysfunction, as the guideline described, could be structural, that is happening inside the valve, or it could be a non structural, that you have a valve embolization, a pannus formation, or a PPM, that is patient prosthesis mismatch, or it could be endocarditis or thrombosis and thromboembolism. If you already, this is another new thing which is added, that in case you are following up the valve and you find these variations from the previous echo report, that means that their valve is getting abnormal. Now, in the mitral valve position, if you have a valve, one thing, the first thing what you look at is whether the velocity is more than 1.9 meter per second, and in case it's more than 1.9 meter per second, second thing what you look as is now here you look at the ski phenomena. The early deceleration should not be taken into account. The deceleration time is the distal part of the diastolic flow across the valve we take, and if the deceleration time, if pressure half time is more than 130, then this indicates that this patient is having valve stenosis. One or two cases I'm going to show you. This is the bioprosthetic valve. Look at the thickening and the calcification of the valve, and again you can look at the doming of the valve here, and it's calcified. Okay, and as expected, you would have a mitral stenosis and a mitral regurgitation because of the degenerative mitral valve you have. And here this one is a wrong. You don't take it at the beard, you take it at the chin. This is the modal velocity, so all the slopes and the gradients have to be taken at a modal velocity rather than this dispersion. So in this patient, you can see the effective area is 1, and then you have a slope, and pressure half time is far more than 130 millisecond. It's 200 millisecond in this case. After stenosis, the guidelines have given a detailed on prosthetic valve regurgitations. Prosthetic valve regurgitation could be physiological, could be valvular, could be paravalvular, and these are called washing jets. and these are normal. In a bi-leaflet you get two jets, in a tilting disc you get a single, and our old friend star Edward a ball cage you get this kind of a broad jet. So these are normal, so please do not report them as abnormal ones. And in the aortic valve, mild paravalvular leaks are pretty common. Reason being, many a times the surgeon would have to enlarge the LVOT to put a larger size valve. But the guidelines have again said that in case you have a prostate aortic valve regurgitation, the parameters are same as the previous guidelines on a valve disease have suggested. Same for the mitral regurgitation, prosthetic valve or a native valve. The guidelines for regurgitation assessment are almost the same. So this is a normal valve, which is you can see both the leaflets 1 and 2, which are opening. This is a bi-leaflet valve on a 2D, and then it's in a 3D. You see the bi-leaflet valve 1 and 2 valves are opening, and this is from the atrial side. 1 and 2 valves are opening. That's pretty normal, but I want you to compare with this. And this is one valve which is opening valve, closing valve, but this one is not staying open for a long time, but its closing also is almost halfway. So this the leaflet or occluder is not moving properly. It's kind of obstructed, and this is leading to the regurgitation. You can see the regurgitation jet. You don't see PISA. Half of the regurgitation jet you see in the LA, and the rest half, proximal one, you can't see because of shadowing. And again on a 3D you can see this valve not behaving properly. This valve is opening and closing valve. This valve is not opening and closing valve. Biprosthetic valve, normally this is how you see it, a mitral valve position, and you can clearly see the valve structure. You can see a normal inflow which is mildly obstructed always in even in prosthetic valve because of the profile of the valve. And then you can see these three studs in the prosthetic bioprosthetic valve, and you can see the valve leaflets on a three-dimensional echo. This is on the LA side, and this is from the LV side. We can patient can get infective endocarditis of the mitral valve, and showing you a case of infective endocarditis damaging both the leaflets, which you could see in this view, and you can see a severe mitral regurgitation because of the shadowing of the studs. You don't see the regurgitation full in LA, but a large PISA alerts you that this is a severe mitral regurgitation and associated with a small aortic regurgitation. On a zoomed view, you can see the vegetations on both leaflets, and as expected, a severe mitral regurgitation seen very well right through the LA, and you can see a severe tricuspid regurgitation which has been cut by the scale. And in case these you can have an imaging, you have a doubt about infective endocarditis, PET CT would come to your rescue, and it can show you inflammation areas around. Then this is the TAVR, and these are the areas where the regurgitations can happen. This I already showed you there, and these are the three places, and you describe it as as a clock, and you can describe where the regurgitation is more than 25% area is abnormal. I'm going to show you abnormal regurgitation from an aortic valve. This is a bioprosthetic aortic valve, and you see there is a kind of a tunnel around the valve. This is dehiscence of the valve, and this was the dehiscence which happened in a post-infective endocarditis patient, and you can see the regurgitation from this dehiscence. On a 3D, you can see the dehiscence here. This is the pulmonary valve, this is the aortic valve, and this is the area of dehiscence, and you can see the dehiscence happening here in the valve, and you can see regurgitation flow from the dehiscence. This is the mitral or the aortic orifice flow, and this is a paravalvular leak. Severer paravalvular leak because of severer dehiscence. You can see two and jets of regurgitation and a forward flow, and this is a apical five-chamber view. Again, you see a tunnel on this side and this side. Are there two tunnels? Actually, no. When we saw on a three-dimensional echo, this is a large C-shaped descent of the valve. Center one is the valve, and this is the descent. So you can appreciate very clearly this patient required surgery and did well thereafter. Another area of echolucency in the front or anterior part of the aortic valve, and you can see there is to and fro flow, and this is a kind of a tunnel which has been formed because of the paravalvular leak, and that's where you can see this descent and a paravalvular leak in this patient. So these guidelines are very, very comprehensive, and I suggest that you read these guidelines right through and through. Thank you for watching this, and good idea that you start subscribing the channel so that whenever I post something new, you would be notified. Thank you very much.